Gosh, you guys are quick. It looks like everyone is joining so quickly. We'll give it another minute or so, and then we'll get started right at 7 for you. And that way we can get you done and get you relaxed in about an hour or so after we get started. All right, you guys are quick. So good evening. I'm Dr. Michelle Travers, and I am the Director of Medical Operations at the Animal Cancer Care Clinic in the South Florida branch. Thank you all for joining us tonight. I know you had probably a very, very busy day, so we appreciate you joining for part one of our 6-part series on how to navigate through the cancer diagnosis. This complimentary lecture series is going to be presented by our practicing medical oncologists and our medical surgeons, who will probably be panelists tonight to help weigh in on some of the Q&A that we'll have at the end of our seminar. So in these 6 lectures, which will be given once a month on Thursdays until the end of August, we will be discussing the 6 more common types of tumors that you'll be diagnosing in private practice. And so the things that we wanted to cover are going to include diagnostics, treatment options, financial responsibility for the treatment options, certainly side effects, duration of therapy, and these are all questions that I know we're faced with every single day when we make that diagnosis. So this program will qualify for 1 hour of complimentary CE done to the state of Florida, and that will be 1 CE for each lecture in the 6-month series. So we'll tell you a little bit more about that when we get to the housekeeping part of it. I wanted to, first of all, give a big thank you to my Elanco rep, Dr. America Lipcomb, and Elanco for sponsoring this wonderful platform that's allowing us to bring you the continuing education for the next few months. So thank you very much. And a big, big thanks to Elanco's specialty group for providing us with all of the wonderful, wonderful, amazing products that they have that allow us to achieve optimal outcomes and give our patients hope. So many products. Tenovia, which is probably one we'll be talking about tonight. Nosita, Entice, Allura, the list is very, very long. So we thank them. We thank the specialty group for allowing us to bring the best to our veterinary patients. So housekeeping tonight, our lectures are going to run about 45 to 50 minutes. And the last 10 to 15 minutes of the lecture, we're going to open up to Q&A. And so throughout the lecture, there's a little box on your screen that says Q&A. If you wouldn't mind just jotting down your questions. And at the end of the presentation, we'll go through all of them and we'll try and get through everyone by the end of the lecture. We're going to have everyone muted and no video tonight just to keep the procedure streamlined for us. So write down those questions and we'll be fielding them at the end of the presentation. As far as getting your CE credit, after the webinar has ended, you will be redirected to a link, and that will go ahead and input your information so you can receive your CE. So really important, if there are multiple doctors from one practice, you all need to include your own personal information to be sure everyone is getting appropriate credit. And we will send out your CE via email, and it will probably take about 2 weeks. If the 2 weeks pass by and you haven't received everything, please reach out to us at the Animal Cancer Care Clinic. And I'll give you that information at the end of the presentation. And I'd like to introduce our first speaker for the series, who will be lecturing on lymphoma, the essentials, and that's Dr. Evan Sones. Dr. Sones is our lead medical oncologist in the Orlando branch. And Dr. Sones was born and raised in Baton Rouge, Louisiana, and he received his undergraduate and his DVM from Louisiana State University. After that time, he did move to Atlanta, Georgia, where he did complete a small animal internship at Georgia Veterinary Specialists. And then he went on to Alabama to complete a medical oncology residency and his concurrent Master's of Science in Biomedical Sciences at Auburn University. So War Eagle, Dr. Soanes.
There you go.
And with that, we will turn the floor over to you for the next 50 minutes.
Thank you. Thanks everybody for joining us for this first of our lecture series. This is my first webinar so far, so it's a little interesting that I'm sitting in my kitchen lecturing to you all, but it's a change. So tonight I'm going to be talking about lymphoma. Lymphoma is probably one of the most common cancers that we see in oncology practice, and probably that you all see in practice as well. So I'm just going to kind of go through the essential things to know, how to diagnose it. There are quite a few new diagnostic tools that are available, so when to use those and what information those new tests give us. We'll kind of review the typical chemotherapy protocols that we use, and then a couple of newer chemotherapeutics that are available now. And then we'll talk about the same type of information in cats as well. So it's kind of a very broad overview. A lot of it is review, but there are a few new things in here as well. So why lymphoma, and why did we choose that as the first cancer? And the reason is that it's just very, very common. So these are the statistics on lymphoma. There are something like 70 million dogs in the United States. So if you look at 84 out of 100,000 dogs over 10 years are going to develop lymphoma, that's a really, really common cancer. There are quite a few breeds that are at a higher risk, and those are listed here. Some of those you think of off the top of your head, boxers and those. And then there are some that are lower risk, dachshunds and Pomeranians. I'm always glad that dachshunds are on that list because I have dachshunds, so it makes me feel a little bit better. So diagnostics. There are quite a few diagnostics for lymphoma. The first is cytology, and cytology is kind of our go-to. It's the least invasive, least expensive. Most patients are cooperative that we work with, so you can easily get it without sedation or anything like that. The results are quick. With these new digital cytology services, you can get the results within an hour or two if you need to. Otherwise, we still get them within a day or two, so we get a quick diagnosis. And you can get a lot of information from the cytology other than just the diagnosis of lymphoma. Cytology can also help you with the size of the cells, which correlates to the grade of the cells. So if a lymphoma is the typical one we see with all the big lymph nodes, those cells are going to be large lymphocytes, and that's similar to high-grade lymphoma. If it's one of the less aggressive forms of lymphoma that we'll talk about, those cells might be small or intermediate size, and that would possibly correlate to a low grade type of lymphoma. So cytology is still our go-to. We get a lot of information and quick diagnosis with that one. Histopathology is a good diagnostic as well. A lot of times we'll go to histopath when the cytology isn't that helpful. It is a little bit more invasive test, does require anesthesia, but it's still not a very significant surgery because the lymph nodes are on the outside of the body most of the time. You can get a lot more information from histopathology. So for example, it's better at typing the lymphoma. You can get a lot more specific information about the specific type of lymphoma, especially if you remove the entire lymph node. There are also some of those indolent or non-aggressive forms of lymphoma that really can only be diagnosed with histopathology. Sometimes you have to send that histopathology sample to a specific pathologist, a hematopathologist that's trained in those trained in differentiating the different types of lymphoma, but for the most part, you don't. You can send it to your go-to pathologist. The results do take a little bit longer, and it is obviously a more expensive diagnostic, and so that's the major downside for most clients. People nowadays want an answer now. Cytology gets you an answer now. Histopath gets you more information, but it's not always worth the wait for some folks. Immunohistochemistry is kind of a step above histopathology. So in some histopath samples, it's still not possible to make a diagnosis of lymphoma, or immunohistochemistry can be helpful in getting an immunophenotype for dogs and cats that have lymphoma. There are also some very rare types of lymphoma, for example, Hodgkin's-like lymphoma in cats that really can only be diagnosed with histopathology with immunohistochemistry. The typical antibodies that are used are against CD3 in T cell lymphoma and CD79A or CD20 in B cell lymphoma. And those markers are also important because there are certain treatments that are aimed at those specific antigens on those cells as well. This is an example of immunohistochemistry. So the top are just the typical H&E stains for the entire lymph node, and then a more magnified sample on the right at the top. And then the bottom two are those same samples with the immunohistochemistry antibodies applied. And so all of the brown areas are going to be the specific lymphoma cells that we look at. So in case you've never seen immunohistochemistry before, that's really all you're looking for is that brown staining. And you just want to make sure that brown staining is on your cells of interest, which are the lymphoma cells in this case. So now we get a little bit more into more advanced diagnostics. And these are diagnostics that have become more and more common just in the past few years. The first one is PAR, or PCR for antigen receptor rearrangement. The main benefit of PAR, and the reason we use it a lot, is for two things. One is for immunophenotype. So it does help us to decide, is this lymphoma the B cell type or the T cell type? The other is in cases where we're just not sure if the diagnosis is lymphoma or not. So for example, you may send in a cytology and the cells are intermediate or small size, and the pathologist just can't be sure if they're lymphoma cells or not. Or if it's there's a lot of inflammation in the sample or something like that where they just can't tell, then PAR is helpful. What PAR does is it's PCR looking at the DNA of those cells. And if you remember back to immunology, lymphocytes have the VDJ region on their DNA, and that region is rearranged randomly in lymphocytes during development so that they can recognize all the different antigens we come in contact with on a day-to-day basis. So what this test is doing is looking at that DNA to see if that VDJ region is amplified, and if all of those lymphoma cells or all of those lymphocytes have the same rearrangement, and so therefore have the same DNA. So a hallmark of cancer is clonality. So if all of those cells have the same DNA, then they're clones of each other, and that's diagnostic for lymphoma. The best thing about PAR is that it can be run with almost any sample. So the cells don't have to be alive, they can be dead. DNA is very, very stable protein. So they can literally just scrape the cells off of the cytology slide with a razor blade and use those cells to run the PAR test. It has a pretty high sensitivity and specificity depending on the lab. Some labs actually have higher sensitivity and specificity than what I have listed here, but this is kind of the go-to numbers at the moment. So PAR is different than flow cytometry. Flow cytometry has to be run on live cells, and those live cells have to be in suspension. So you want to run it on something like a lymph node aspirate that you put into suspension, or you can even do like a splenic aspirate that you put into suspension. The easiest ones are going to be blood. You can run it on cerebrospinal fluid. So any sort of liquid or suspension of cells, you can do flow cytometry on. It's really important that you use the tissue of interest though. So for example, if the dog has lymph node lymphoma, you have to sample the lymph node to run the flow cytometry. If they have splenic lymphoma, you have to sample the spleen to run the flow cytometry. So if a dog has lymph node lymphoma, then you don't want to run flow cytometry on the blood because those cells may not be in the blood. The only time you would run flow cytometry on the blood is if the lymphocyte count was high on the CBC, and then you could tell that those lymphoma cells were there. So you really need the cells of interest to be able to run this test. It's really minimally invasive, gives you the immunophenotype, but it also gives other prognostic markers such as the size of the cells. Expression of MHC class 2 has been found to be a prognostic marker. There are other CD markers that we look at that give us a lot more information. This is just how flow cytometry works. So the sample is sent, the liquid sample is sent through the machine, a laser light is shined at the cells, and then the computer can interpret the scattering of that laser light to determine what type of cells are present. And then also certain stains are applied for each of those different CD markers, and they have different fluorescence. And so the machine can tell the difference between those as well. And so we end up getting a big report like this. This is an example of a flow cytometry result from the Colorado State University Immunology Lab, which is the one that we most commonly use. So I have 4 of these just to kind of go through them. You can see at the top, it tells you what % of cells are dead. So these are live cells that we're putting into suspension and then sending to a lab through the mail. So some of those cells are going to die, as long as it's not a very high percent. 10% is pretty common, sometimes up to 20%, then it's okay. If too many of the cells die in transit, then they won't be able to run the flow cytometry. However, they can still run PAR, because remember, those cells don't have to be alive to run PAR. So it's common for us to send the cells if they don't make it for some reason because of a shipping delay or the weekend or whatnot, then we'll still have the PAR run on that same sample. The next is the size of the cell. So the majority of lymphocytes in a lymph node should be small cell, probably about 80% of them, and then about 10% medium size and about 10% large cells. So you can see in this sample that 78% were small, 22% were medium or large. So that seems like a pretty normal distribution. In a lymph node, there should be about 50-50 of T cells and B cells. So you can see here that the pan T cell markers CD3 and CD5 make up about 51 and 52% of the cells, and about 45 are B cells. So that's pretty typical of a lymph node. So this is actually flow cytometry on a normal lymph node. So you can see the 80% small, 22% medium, large, 50-50 B cells and T cells. And then there's a few other cells like neutrophils and monocytes that are there as well. This next report is on a typical lymphoma. So you can see that only 4% of the cells were dead, which is really good. Only 10% of the cells in the lymph node were small cells. So that's complete opposite of what we expect to see. 90% of those cells were medium or large cells. And that's what we expect to see in patients with lymphoma. And then if you look at the markers that they express, only about 1% of those large cells had the T cell markers, and about 98% had the B cell markers. So this is consistent with diffuse large B cell lymphoma, which is the most common type of lymphoma that we see. There's a couple of prognostic markers that have been found for B cell lymphoma. You can see at the bottom. So one of those is forward light scatter, and one of those is class 2 level, which I mentioned before. So you can see they're medium size and high expression of MHC class 2, and both of those are considered positive prognostic markers. The next is another example, again, 7% dead, which is good. The majority of those cells are medium or large cells, which is typical for lymphoma. Then you can see of those medium or large cells, 96% express the T cell marker, only 1% the B cell marker. So this is T cell large cell lymphoma. And then the last one, you can see that the majority of these cells are small cells, which we expect to see, although this is a higher percent than we normally see at 98%, and about 2% are medium or large cells. You can see that the majority of those are T cells, but they're small T cells. So then we have to look at another marker called CD45, and we want to see at the bottom here that those cells are CD5 positive and CD45 negative. And this is actually diagnostic for an indolent form of lymphoma called T-zone lymphoma. So T-zone lymphoma is small T cells with a loss of expression of CD45, and that's diagnostic for that. So flow cytometry not only can diagnose lymphoma, the typical type, but also the indolent forms. And then also there's another marker in here. I don't have an example of it, but CD34, and CD34 positivity is consistent with acute leukemia. So flow cytometry can also differentiate acute leukemia from large cell lymphoma, which is helpful in a lot of cases. We're finding out more and more that dogs that we think have lymphoma actually have leukemia because they can be totally non-leukemic. So they have leukemia, but they don't actually have those cells in circulation. We actually find it in the lymph node, but they're CD34 positive. And this is brought up more and more that there's this kind of blurred line between lymphoma and leukemia in a lot of patients. So it's kind of changing a little bit. So the reason I go through all of those, when you send in those samples, you get an interpretation. So you don't have to interpret all this data on your own. The immunologist will interpret it and give you the results, you know, to say, oh, this dog has B-cell lymphoma, and this is the type and that sort of thing. But it's helpful to know where they're getting that information from. And this is an easy test to run. It's not very expensive, and it gives a lot of information. It's really helpful for clients, I think, to have this information. There's a new test that we have not started using yet, but we will be starting to offer soon. I don't think it will be used very commonly, but I just want to mention it in case you hear about it. There's a company called Impromed, and you send in a lymph node sample, same as we normally do, but we get flow cytometry and PAR as well. And then this company actually has a way to use artificial intelligence to predict which drugs the patient is most likely to respond to based on that patient's individual lymphoma and leukemia cells, and then a database that's known about lymphoma in dogs and drug sensitivity. So it's an interesting new diagnostic tool that's out there. Again, we haven't started using it yet. We're having training on it in a couple of weeks, so you may start to see us use it a little bit, but it is becoming available. All right, staging. So this is the stages for lymphoma. I think everybody kind of knows this. Stage 1 is one lymph node. Stage 2 is regional lymph nodes that don't cross the diaphragm. Stage 3 is generalized lymph nodes. 4 is liver or spleen. 5 is bone marrow or blood. We also have a substage in lymphoma. So substage A means they have no systemic signs, and substage B means that they do have systemic signs. So the typical staging that is recommended for lymphoma patients are baseline blood work, so CBC, biochem, UA, chest x-rays, abdominal ultrasound with spleen and liver aspirates for cytology, and the bone marrow aspirates, and that's how we get all of those different stages. But something that's important to know, and this just comes from being practical, is that we don't necessarily have to have all of those tests. And the reason is that the stage of lymphoma is not necessarily associated with a prognosis. So for example, a dog with stage 3 that has big lymph nodes versus a dog with stage 4 that has spleen or liver involvement, there really isn't a big difference in the survival time or the treatment between those two stages. Stage 5 in some studies, so that's when the lymphomas in the bone marrow or the blood, they do have a difference in their outcome with that particular stage. So that's where the bone marrow aspirate becomes helpful. I kind of suspect that those studies were done before flow cytometry was very common. And so I kind of wonder how many of those patients actually had leukemia, and that's why they did worse if they had stage 5 lymphoma. That's something we won't know, but can look at going forward. But in general, we offer all of these staging tests, but the majority of the time we don't really do a lot of them, like especially the more invasive ones, for example, spleen and liver aspirates and bone marrow aspirate, because it's not really going to change a lot for the client or for the patient. So we try to be practical and save a little bit on resources to put towards treatment, and we often will forego some of those tests. There are a lot of factors that do affect the prognosis, though. One obviously is the grade. So, and that correlates again with the size. So indolent lymphoma versus high-grade lymphoma, low-grade versus the high-grade lymphoma. Again, high-grade is much, much more common, but it does influence the prognosis. Some of those flow cytometry markers that we talked about. So large cell lymphoma can be medium size or large size on flow cytometry, and there's a difference in prognosis between those. Some of those markers we look at, like CD MHC class 2, if there's high expression of that versus low expression of that, those also correlate with prognosis. The immunophenotype, so we know B cells better, T cells tougher. Some people say B cells better and T cells terrible, but I just like to say tougher. Also, dogs that have hypercalcemia or a mediastinal mass, that's more associated with a negative prognosis. Response to treatment, which makes sense, but it is a really big prognostic factor. So if you start giving the chemo and it doesn't work, then that's probably not very good. The substage, which I mentioned before, dogs that are healthy when they come in versus dogs that are sick from their lymphoma. The ones that are sick, obviously, that's a negative prognostic factor. And then pre-treatment with prednisone is very consistently a negative prognostic factor in every study that has been done looking at pre-treatment with prednisone. Prednisone, again, induces the multi-drug resistance gene. So treating with prednisone prior to chemotherapy causes the lymphoma cells to become resistant to chemotherapy by inducing that drug pump to get the chemo out of the cells before the chemo is able to work. It's not clear how long a patient can be on prednisone prior to starting chemotherapy before that happens. In a lot of cases, it's necessary. The dog is very sick and is diagnosed with lymphoma and is not going to be able to start chemo for some period of time. So sometimes we have to do it out of necessity just to make them feel better. But ideally, they would not be started on prednisone prior to starting chemotherapy. So typically at our practice, the recommended staging is the baseline blood work and the immunophenotype in whichever way it is easiest to get that. And then the other tests, chest x-rays, ultrasound, bone marrow, are really going to depend on the clinical signs and the blood work findings, as well as the client and any limitations that they might have. So classification. So these 3 slides, I'm just going to go through them quickly, are the human classification of lymphoma. So there are many, many, many different types of lymphoma and subtypes of lymphoma and leukemias and different things in human medicine. Obviously in dogs, we don't have quite as many, but there are still quite a few. So these are all the B cell lymphoma and leukemias. The most common one that we see is going to be that diffuse large B cell lymphoma. That's what, the common golden retriever is going to get. And then these are all the T cell lymphoma and leukemias. And we typically just see large T cell lymphoma in dogs, but there are lots and lots of different kinds. All right, chemotherapy and prognosis. So this is a really important slide. So this is kind of for your typical high-grade multicentric lymphoma patient, the happy, healthy golden retriever that has big lymph nodes and is diagnosed with lymphoma. These are kind of all the options that we present to them at the initial consultation. So, you have all of these different options to look for. CHOP is, or UW25 or 19 or whichever one that you follow, is kind of the go-to for lymphoma in dogs. It has a very, very high response rate. So for B cell lymphoma, 85 to 90% response rate. Median survival time of 11 to 16 months, with about 20% of dogs living to 2 years and about 5% to 3 years or more. Dogs with T cell lymphoma, we can certainly use CHOP as well. There's about a 75% response rate, and the median survival time is about 6 to 9 months. Adriamycin is one of the drugs in the CHOP, so that's the H of the CHOP. The H comes from the chemical name for adriamycin. And you can use that drug by itself, because out of the CHOP drugs, it's probably the one that's the single most effective. And so if you use it by itself, you give it just once every 3 weeks. So it's a lot less treatments. The CHOP is typically 16 treatments. Adriamycin is typically 5 treatments once every 3 weeks. And the response rate is about 75%, with a median survival time of 7 to 9 months with that protocol. So still very good. I have a lot of clients that say, well, it's 7 to 9 months is not that different than 11 to 16 months. They always tend to pick the highest of the one they want and the lowest of the one they don't want to make their point. But the main difference between those two is that 2-year and that 3-year survival rate, because we really don't see that with single agent adriamycin. We really only see that with CHOP-based therapy. Lomustine or CCNU is a very attractive option. It's an oral chemotherapy that's just given once every 3 weeks. It's very well tolerated, but the response rate and the median survival time are a little bit shorter than the others. Prednisone obviously is our go-to for palliative care if chemotherapy is not elected and has a median survival time of about 1 to 3 months. L-asparaginase or L-SPAR, we use a lot as an induction drug to get them into remission as quickly as possible, but it can also be used in place of chemotherapy if the client doesn't want chemotherapy, and you kind of just give it as needed. So most of the time it works several times, and every time you give it, the length of time it works kind of cuts in half, so it works for less and less time, but it often can kind of eke out a little more good time than just prednisone by itself. There's a lot of rescue therapies as well, MOP, MOMP, LOP, DMAC, melphalan, all of these are considered rescue therapies. LOP is a combination of lomustine, vincristine, procarbazine, and prednisone. And LOP has actually become my go-to chemotherapy protocol for dogs with T-cell lymphoma. So rather than starting with CHOP, I'd now start with LOP for most of them. And the reason is that there's a couple of papers that have come out that have shown a much higher median survival time, closer to a year actually, for dogs with T-cell lymphoma when they are started on the LOP protocol versus a CHOP protocol. So that has been a change that I personally have made, but I don't know that all oncologists have made that change at this point. Nor should they, but that's just my personal preference. And then Tenovia is a newer chemotherapeutic to us. So it's actually the first ever FDA conditionally approved drug for dogs with lymphoma. It is still conditionally approved, so we have to follow the rules very closely and follow the label very closely. But it is a very good drug to add to our arsenal. There are several studies. I think there have been 6 studies published so far with Tenovia, looking at it as a frontline chemotherapeutic, looking at it as a rescue, alternating Tenovia with adriamycin. There's a newer one with Tenovia and L-asparaginase. So those are all published at this point. It is a 3-week dosing, so one treatment is given once every 3 weeks. It can be used as frontline or rescue. There's no limitation in the label at this point. The side effects that we see are pretty common to most chemotherapeutics. Typical GI is possible, although very manageable for most patients. There are some side effects that are not common to most chemotherapeutics, but they're very uncommon to see. They occur in a very low percent of patients, and those are dermatologic side effects and pulmonary fibrosis. Those are not ones we typically see with a lot of the other chemotherapies we use, so it's important to mention that to clients, but again, they're very low percent of cases where it happens. So in our practice right now, we're typically using Tenovia as our first go-to after CHOP protocol. So they tend to go to the CHOP first, and then we use Tenovia as our first rescue. And so there is a paper published in that exact situation. So the response rate as first line rescue after doxorubicin-based protocol, which would be CHOP, or doxorubicin, which is also adriamycin by itself. So the overall response rate was 74%. Including complete, partial, and stable disease. The median response duration was 172 days, which is pretty good, considering they've already been through one chemotherapy protocol. And those dogs that had a complete response actually had a median response duration of 215 days, which is really impressive for dogs that have already been through one chemotherapy protocol. So this is a really good option, just because they don't have to go back through the whole 16 treatments again. They just have to get 5 treatments. So it's really attractive for a lot of clients. So there are definitely some less common types of lymphoma. One good example is indolent lymphoma. I've mentioned that a couple of times. Indolent lymphoma is a very slowly progressive form of lymphoma. So it's going to be those dogs that have small cell multicentric lymphoma instead of large cell multicentric lymphoma. And we talked a little bit about T-zone lymphoma in the flow cytometry section, and T-zone lymphoma is one of these types of indolent diseases. There's also one called marginal zone lymphoma, which can be splenic or nodal. And then chronic leukemia falls under this category as well. And so these are lymphoma and leukemias that a lot of times we actually don't even need to treat. Because they're so slowly progressive, patients can live for long periods of time without any sort of treatment. We look for certain things like, is the patient sick from the disease? Are, for example, the other cell counts going down in cases of leukemia? Like, are they becoming anemic or thrombocytopenic? Some people look at if they have a leukemia, what's the count of that? How big are the lymph nodes? So any sort of signs that the cancer is behaving more aggressively or affecting the patient's quality of life, then we would start treatment for that. And typically the treatment's going to be just chlorambucil and prednisone. Chlorambucil is Leukeran, which is an orally administered chemotherapy that's really given at home. And then obviously we all know about prednisone. Some other lymphomas that we see are cutaneous or epitheliotropic. This is a little more aggressive form of lymphoma. We give them a little more guarded prognosis of about 6 months with this form, and really because they almost always respond to treatment, but the duration of that response just isn't very long for most patients. And lomustine or CCNU is usually our first go-to for that. But I will say that and this is something that we've kind of thought for a long time, but is finally getting its way and making its way into the literature, is that there seem to be several different forms of cutaneous or epitheliotropic lymphoma in dogs. One differentiation is the mucous membrane associated versus haired skin. So these are the dogs that the mucous membrane form, they come in and they have like lip lesions or gum lesions, or, in their nail beds or their pads or their anus or something like that. And their skin looks fine, versus the dogs that come in with these big ulcerated, oozing, haired skin lesions. And there was a paper published that showed the mucous membrane form did have a much better prognosis than dogs that had the ulcerated, haired form. And I also personally think there are probably a couple of different forms of the haired skin, where some are more indolent, like those indolent lymphomas we talked about, and some are more aggressive. Because sometimes you see these dogs that have just the kind of this scale itchiness that goes on for a very long time and just can't be rectified, and then biopsy and find out it's lymphoma. And then sometimes you see these dogs with these big ulcerated, oozing, bleeding wounds, and those dogs are very different than the first. So I think that's another differentiation that probably needs to be made in the future, because I think they behave very differently. But as of now, it's not published anywhere that those are. That's just my personal take on it. Alimentary lymphoma is not very common in dogs compared to cats, but it does happen, and it's usually high grade. Again, a more guarded prognosis with an average of about 6 months. And again, the reason is just a poor duration of response. We give them the chemo, they get better, and then it stops working very quickly. A lot of times we use CHOP therapy for that, although lomustine is a good choice as well, because a fair number of those are going to be T cell, and lomustine probably works better for those. And then there are some less common treatments that are worth mentioning. One is radiation therapy. So we typically think of lymphoma as being a systemic disease, and so systemic disease needs chemotherapy because chemotherapy goes everywhere. Radiation is typically a targeted therapy, so you aim it where you want it to go, and it doesn't really affect the rest of the body. And so when we're using radiation therapy to treat lymphoma, if it's a systemic disease, we have to irradiate the whole body. The problem is that if you irradiate the whole body, then you can't really survive that. And so the only way to accomplish it is to irradiate half of the body at a time. And so patients can get what's called half body radiation in combination with chemotherapy, where they get some chemotherapy to go into remission and then have half of their body irradiated. Then they get more chemotherapy and the other half of their body irradiated. And the big draw to that is that there are several papers that are published that showed a higher median survival time with this form of therapy. And similar to CHOP, there are some patients that live for many, many years with half body radiation and chemotherapy. And so it's really an attractive treatment for that reason. However, it's a bit of a challenge for the patient. We see a lot of they do well with it, but we see a lot of difficulty in continuing the chemotherapy with things like neutropenia and thrombocytopenia just because so much of the bone marrow is being irradiated. So we do see some more long-term complications of that. Bone marrow transplant is being done at a few places around the country. The big push for bone marrow transplant is that it is the treatment that's done in people who have curable forms of lymphoma that are not cured by chemotherapy. They tend to get a bone marrow transplant, and that does carry a chance of cure for them. And so the idea was that could we do bone marrow transplant in dogs where the procedure was originally developed in dogs, so we know how to do it, and then have a chance of curing those patients. And there are some that probably are. My take on it is that it's a very complicated procedure. They do, because they're getting high doses of chemotherapy and high doses of radiation to kill the bone marrow, they do have quite a bit of complications from that. So their white blood cells and platelets go down to 0. They're usually hospitalized for several weeks. And then there is a fairly high chance of mortality with this procedure. I think it varies depending on the facility that's doing it, and it has improved dramatically since it was first being done. So there are clients that are interested in it, and it is available. But I think it has to be a really special client and a really special patient to be willing to go through the things that they have to go through, but it does carry the chance of a cure. There is a canine lymphoma vaccine that's produced by Mariel. It has a conditional license as well. It's a DNA vaccine against CD20, which is a marker for B cells. So it's really a B cell lymphoma vaccine. It's similar to Mariel's melanoma vaccine, where they're using xenogenetic technology. So for the melanoma vaccine, they're using human DNA. For the lymphoma vaccine, they're using mouse DNA. The problem with this vaccine is that it was conditionally licensed in a very, very small number of dogs. So the entire study had 11 dogs. 2 of those dogs were not applicable by the end of the study. So there were 4 dogs that completed the CHOP protocol and then got the vaccine. And then there were 5 dogs that did not. And so you can see the median survival time for those 4 dogs that got the CHOP and vaccine was very, very high. But we haven't seen any mature data since then to know whether it's really useful or not. So it is available, and some clients do request it, and we do offer that. But whether it's really helpful, I think it's still a little bit, the jury's still out on that. And then there is a new drug that's coming out. It's not available yet. It's coming out on the market soon, called Laverdia. And Laverdia is the first oral treatment conditionally approved by the FDA for canine lymphoma. So this is going to be an oral drug that's used to treat lymphoma. We don't really know too much about it at this point. I think it's going to be interesting to find out whether it should be used by itself or if it should be used possibly in combination with other drugs, but we don't really know too much at this point. I just mention it because it will be available probably within this year. So we'll start getting questions about it soon, I think. All right, so feline lymphoma. Of course, I don't have quite as much about cats as dogs, which is very typical, and I apologize to the cats for that. But feline lymphoma is typically almost always GI. They can get multicentric and the other forms like cutaneous and that dogs get, but they're just far less common. The biggest distinction for cats is whether the lymphoma is small cell versus large cell. Small cell GI lymphoma is actually a little bit more common, and it follows the same as small cell lymphoma in dogs, where it's more indolent in nature, so it's very slowly progressive. We typically treat it with chlorambucil and prednisone. The vast majority of cats will respond, although it takes a little while for them to respond, they usually do. And the survival times are very high, so typically greater than a year, and often for many years. I mean, we all have cats that are 2 and 3 years out with this particular type of lymphoma. They can get large cell lymphoma as well. This is a much more aggressive form. We usually start with CHOP-based chemotherapy, although lomustine or CCNU is a very reasonable option There hasn't been a paper published comparing those two head-to-head, CHOP versus lomustine for large GI lymphoma in cats, but there is a paper published that showed the response rate of each, and they're very, very similar. But CHOP is still our go-to for this particular type of lymphoma. And cats will fall into one of three groups. So one group is the non-responders. So they're just not going to respond to chemotherapy no matter what drug that you use. And that's probably about 20 to 40% actually, depending on the study. We have the average responders, and those cats are going to respond. It's going to take a little while, a few weeks to get them back healthy again. And that's going to last about 8 to 10 months. And then we have a small group, probably about 10 to 20% that have a really great response. And those cats go into remission right away, finish their treatment and live another 1 to 2 years. So that's not the common cat, but we do certainly see that. Surgery for GI lymphoma cats is still reserved for cats that have obstruction, or if you just can't get a diagnosis. So those small cell GI cats where we don't know if it's inflammatory bowel disease or lymphoma, full thickness intestinal biopsy is still the diagnostic of choice for that. You can aspirate intestines or lymph nodes and run PAR on that if you can't get the diagnosis of small cell lymphoma. So that's a useful tool in this situation. And then there is one paper that suggested possibly doing surgery for cats with a large mass in their GI is helpful prior to chemotherapy, but I don't know that that's really mainstream at this point. Cats with lymphoma really have minimal prognostic indicators. The biggest one is response to treatment, which makes sense. And if it works, that's great. And if it doesn't, that's bad. But all the same prognostic markers that have been looked at in dogs are the same, have been looked at in cats, and they just really don't pan out quite as well. There are obviously some species differences in dogs and cats based on for example, the dosing that we use and some of the toxicities, and there are some drugs we use in cats that we don't use in dogs. So there are some differences there. So kind of in summary, lymphoma is very treatable cancer, but it's not curable. So that's my favorite phrase to tell. It's not my favorite, but it's a very common phrase to use with clients, that it's treatable, but not curable. There are a lot of diagnostics available now. Flow and PAR are becoming very, very common place in treating dogs and cats with lymphoma for diagnosis, as well as just getting more information for prognosis. Chemotherapy is still the treatment of choice for lymphoma. And some of these newer treatments may make an impact in survival time after many years of none. The treatment for lymphoma with CHOP has been the same for before I was in vet school, and it hasn't really changed. And maybe these new drugs like Tenovia and these others that are coming out are really going to hopefully make a big impact in the treatment of dogs and hopefully cats too with lymphoma. All right, thank you very much.
Dr. Stones, that was absolutely fantastic. Thank you so much for that lecture. We have a fantastic audience tonight and lots of really great questions. So I think what I'm going to do is try and roll a couple of the similar questions together for you. And everyone seems to be very interested in flow cytometry. So a lot of the questions wanted to just have a repeat of the best sampling procedures for flow, including what you're suspending the cells in, and the tissue samples, are they sent refrigerated, frozen, that kind of thing?
Okay, those are very good questions. So like I said, our go-to lab for flow cytometry is the Colorado State University Immunology Lab. And I think a lot of the big labs like Antec and IDEX actually just send their samples directly to CSU. Another big lab is NC State, North Carolina State. So really you have to check with your lab as far as what sample they want in the sample handling. But for CSU, and it should be the same for Antec and IDEX, you typically we're doing a lymph node sample. So you just do a lymph node aspirate the same as you would for any other lymph node aspirate, but you just put those cells directly into 1 ml of saline in an empty, blood collection vials. I don't know what they're called now, non-additive one. So 1 ml of saline, add your cytology sample to that. And then you want to put 0.1 mLs of serum from the same species. It doesn't have to be the same patient, but it has to be the same species. So you want to get 0.1 mLs of serum from a dog and put it into the sample as well. And the reason is that you need that to feed those lymphoma cells or the lymphocytes to keep them alive. And then it does have to be sent overnight, and it does have to be sent cold. And so ours go directly to CSU. So we have through FedEx a way to ship them directly there overnight, refrigerated, so that they arrive alive next day. And again, the sample that is going to depend on your tissue of interest. So the most common is, enlarged lymph nodes. We want to sample the lymph node because that's where the lymphoma cells are. If there is a lymphocytosis on your CBC, then you can use the blood. But if there's no lymphocytosis on the CBC, but the lymph nodes are big, then you really need to sample the lymph node because that's where the lymphoma cells are. If you sample the blood, then you have a very high chance of missing the lymphoma cells and not getting the answer that you're looking for. So that's a big important point.
Great, thank you. And then we had a couple questions on half body RT and the interval between treatments.
That is something the radiation oncologist will be able to answer, but I'm fairly sure they're pretty back to back. So there's not a long time, and it depends on the protocol because there's quite a few different protocols that are used. Because there's several different papers published, but it's not very long. So usually they go through enough chemotherapy to get into remission. So it's usually about 1 cycle of CHOP, and then they get a dose of the half body radiation therapy, and then they might get 1 or 2 doses or maybe 1 more cycle of CHOP and then get the other half of their body. So there's not a big interval between those, but when we have our radiation oncology talk in a few months,
stay tuned on that one.
Yeah.
More to come down the road for sure. And then another good question on Tanovia, lots of interest in that. Inquiries as to using it instead of PRED or using it as palliative therapy for folks not wanting to go forward with traditional CHOP protocols.
So that's a good question. So the way that I think of Tanovia is that it's chemotherapy. I mean, that's really what it is. So it's really just another chemotherapeutic we can use. I think it's a good alternative to CHOP if they don't want to go through all of the 16 treatments of CHOP, because it's only 5 treatments of Tanovia. So I think that's a really good use for it, but it's not palliative care. It's not replacing prednisone. It's treatment. It's literally treatment. It's just a different chemotherapeutic that we have not had available before. So that's where we would use it.
Great answer. Yep, that makes perfect sense. And then lots of kitty lymphoma questions.
Okay.
Which is a popular one in private practice, as we know. And so this actually is a great question. Just kind of wanting you to go down the diagnostic list of how you would work up a kitty that comes in that you're suspicious of having lymphoma.
Mm-hmm. And so that's a good one. So there's a lot of branches to that list, but I mean, generally, these cats, we all know they're going to be chronic vomiters or chronic diarrhea or weight loss, something like that. And that leads us to doing an abdominal ultrasound eventually. Sometimes they just have thickened intestines. Sometimes they have enlarged lymph nodes as well. And those are the cats that are probably going to have small cell lymphoma and are going to be a challenge because it's hard to differentiate that from inflammatory bowel disease. That's very different than the cat that's perfectly fine and then all of a sudden vomits every single day and loses 3 pounds and has a big mass that you can palpate. Those cats are probably going to have large cell lymphoma. And that's much easier to diagnose, right? Because if you can palpate the mass or you can see it with ultrasound, you just aspirate it, you get your diagnosis and you move on. The small cell versus inflammatory bowel disease, those are the ones that's a challenge. And there are a number of things that you can do. Obviously, the gold standard is still full thickness intestinal biopsy. So that's always the go-to. A lot of times we try endoscopy first, and endoscopy can be helpful, but if the lymphoma is too deep in the wall of the intestine, you may not get that answer. But sometimes you can, or you can use that endoscopy sample to run PAR, which will look for clonality of those cells. Another option is ultrasound guided aspirate of the intestinal wall if it's thick enough, or enlarged lymph nodes. Because that may give you your cytologic diagnosis, or you can then run PAR if you need to. So the key between those two is that and why I keep saying PAR is that inflammatory bowel disease is an inflammatory disease. And so that's going to be B cell lymphocytes and T cell lymphocytes. And those cells are not going to be clones of each other because they're all coming in to do their job. Whereas lymphoma is going to be a clonal population of cells. So it's going to be all B cells or all T cells. And then the PAR test may be able to detect that. So that's where PAR is really useful, in that if you can't make a cytologic or histologic diagnosis, it then looks at the DNA of those cells to tell the difference between them.
Perfect. You just actually covered 4 questions.
Oh, good. Hopefully that made sense, because it was kind of circling around, but.
Perfect. You just hit 4 other questions. And then another interesting question that we have, they want to know why some cats and dogs just don't respond to chemotherapy, and is it genetically programmed?
It's a very good question. And I don't know that I know the answer to it. I can speculate a little bit.
Yeah.
So a lot of the reasons that chemotherapy stops working too are just that the cells develop ways to get around it. So I mentioned that P-glycoprotein pump with prednisone. So there's this whole set of these drug pumps that we call them drug pumps, but they're really meant to, for example, if you ingest a toxin, right? So something that's poisonous to your body and it goes into your cells, these are pumps that are naturally meant to get rid of that toxin as quickly as possible. And so the cells, when we use chemotherapy, the same thing happens. It's toxic to the body, so the cells get rid of it as quickly as possible. If there are too many of those drug pumps, or they're overactive for some reason, then it may get rid of that chemotherapy faster than it can work. And so when we give, for example, prednisone prior to treatment, it induces that drug pump. So there's way too many pumps, and all that chemotherapy is pumped out before it has a chance to work. But it specifically works on naturally occurring chemotherapeutic drugs. So for example, vincristine, which comes from a periwinkle plant, and adriamycin, which comes from a fungus. So those are naturally occurring toxins, just like these pumps are made to pump out. And so that's why. So to answer the actual question is that I think sometimes lymphoma is born with those pumps already ready to go. And then before the chemo has a chance to work, it doesn't work. The other reason I think, and this, I could talk about this all day, but the other reason I think is that, I'll just say one more and then I'll move on, is that in order for chemotherapy and radiation therapy to work, we're still a little bit dependent on normal cellular mechanisms being in place. So we're counting on damaging the DNA or some part of the cell enough that the cell uses its normal cellular programming to die. And so if that normal cellular programming is broken, then we could damage the cell, but the cell doesn't even realize that it's damaged or doesn't care. And then it just keeps living anyway. So it just kind of ignores its normal cellular mechanism that it's time to die because I'm broken, and it just keeps living. So there's lots and lots and lots of molecular reasons that we don't need to talk about, but I think those are 2 examples to answer that question.
All right, let's talk a little bit about Impromed, because there's some questions on why we don't think it's going to be used often.
Well, first of all, I don't know that much about it. So I haven't used it and I don't know. I think it's really attractive. It's a really attractive idea. I don't know how well it works. So I guess we'll have to see that. It's quite expensive. From what I understand, it's quite expensive test. So I think it's going to probably be a little bit cost prohibitive for some people, but maybe not for all of them. So I don't know that I can comment too much because I don't really know that much about it yet. Hopefully it's going to work great and we're going to use it all the time, but I guess I just don't know.
That'll be another stay tuned one for the next one.
Yeah.
And then I think we actually have time for one more question if you're up for it.
Sure.
And the question is confidence in the NUQCN screening test.
I don't know that. Oh, I know what that is.
Okay.
Out of Texas A&M. Right? I think that's a new, it's a new cancer diagnostic out of Texas A&M. Again, I don't really know a whole lot about it, to be honest with you. I'm aware of it. I haven't started using it yet. I don't know if anybody else on our panel has any comments about that, but I think it's so brand new. We just really haven't had a chance to really use it enough for me to make a comment. Anyway.
Another stay tuned one. So hopefully everyone will come back for the next few months to hear the answers.
Maybe
to
we'll have an update at the end, like all these.
That'll be our goal.
Yeah.
Well, I just wanted to thank everyone for joining us tonight. Some great questions and great interaction. And I wanted to remind everyone, don't forget, after the webinar ends, you do want to stay online. There will be a link that will redirect you to input all of your information for the CE certificates. And again, you should get those within a 2-week period. If for some reason you don't, feel free to reach out to me at Animal Cancer Care Clinic, and I'll be happy to look into that for you. And we hope you will join us in April the 22nd. That will be our next lecture in the series. And that will be Dr. Erin Roof presenting on mast cell tumors, which I know are probably one of the biggest challenges in private practice for all of us. So I want to thank you, Dr. Soanes. That was a wonderful presentation. Thank you for sharing all of your knowledge with us tonight. That was fantastic.
Thanks.
And I hope you all have a great evening. And remember to stay online, and we'll go ahead and get you redirected to that link. Thanks, everyone. Have a great night. Bye-bye.